Hi, my name is Sarah Austin, and I'm a clinical genetic counselor at University of Michigan. Today, I'll be presenting about an introduction to cancer genetics. And I have no conflicts of interest to disclose. So getting started, we know that around 5 to 10% of all cancers are due to hereditary risk or due to a gene mutation that's inherited or passed down from generation to generation within a family. Individuals that have hereditary risk for cancer have a significantly increased risk for cancer and multiple different types of cancer over their lifetime. And we'll cover more of this later in the series. Another 10 to 20% of cancers are what we call familial, where we may see more cancers in a family than we would expect by chance alone, but there isn't an identifiable or known genetic cause that's contributing to the cancer risk in that family. We think this is because families share a lot of information. They share the same genes and genetic information, but they also share a lot of lifestyle factors, where they grew up, things that they may have experienced over their lifetime that also could impact cancer risk. And then by and large, the majority of cancers we see are sporadic, and those are ones that just happen by chance or by other environmental factors that occur over the lifetime. We know genetic testing is most beneficial for those with a suspected hereditary risk for cancer, and those are individuals who maybe have an early onset cancer, certain cancer types, or cancer at certain sites in the body, or have multiple family members over multiple generations with the same or related types of cancer. And I'll share a couple of examples of these on the coming slides. We also know some cancers are almost always environmental, things like lung cancer, non-melanoma skin cancers, head and neck squamous cell cancers can be due to things like tobacco use, sun exposure, viruses, and are not typically associated with hereditary risk, but this may change over time. When we think of hereditary cancer testing, the goal is to help give us a better understanding of the cancer risk for our patients and for their relatives. We see that there's three main benefits. One is that genetic testing can allow for increased cancer screening or surveillance. So individuals may be followed more closely, for example, having colonoscopies every 1 to 2 years rather than every 5 to 10 years. Or they may undergo screening that they might not have been recommended otherwise, like thyroid ultrasounds or kidney ultrasounds, if they're found to have a gene that has that increased risk for cancer. Genetic testing can also help inform treatment decisions for our patients. So patients may opt to have a different surgery or a different type of therapy depending on their genetic status. So for example, a patient might opt to have a bilateral mastectomy given risk for an additional breast cancer rather than having a lumpectomy for treatment. And genetic testing can also provide information for family members. It can help relatives have a better understanding of their own cancer risk so that they can be screened appropriately. And again, may start cancer screening at earlier ages or make family planning decisions based on their genetic status. When we see a patient for genetic testing, there's three potential results that we can get back from the genetic test. The first is positive, which means a pathogenic variant or a gene mutation was identified associated with increased risk for cancer. This is where we would change someone's screening or surveillance or recommend testing for other relatives if they get a positive result back. The second result we can get is a negative result, which means that we did not find a gene mutation or pathogenic variant or anything on the testing that we think would explain their risk for cancer. A negative result does not rule out all family risk. It just means that we couldn't identify a genetic variant on the testing with the current technology and information we have available right now. And individuals in a family still may need increased screening if there's cancer in a family without a known genetic variant. So for example, if a patient's mom had breast cancer at a young age and our patient was tested and not found to have a gene mutation, she still may need increased breast cancer screening based on the family history alone. And the third result we have is a variant of uncertain significance, or a VUS. This is when we find a change in a gene, but we don't exactly understand what this means in terms of cancer risk right now, and therefore it is unknown or uncertain. We don't make any medical management recommendations based on uncertain results, and the vast majority of these end up being reclassified or changed to a benign result as we get more information over time. I tell my patients that we really don't get too concerned about these. They come up about 30% of the time when we order genetic testing, and we can learn more information on the future about these results that may impact their care. So I had mentioned that there are certain cancers and patterns of cancer in a family that raise more suspicion for hereditary risk. And these are some of the red flags that we would see in someone's own history or family tree that may warrant genetic evaluation. So some of these include young onset cancers. Generally, we say this is at age 50 or younger for most common cancer types like breast, colon, endometrial. So anyone that has a personal history or family history of young onset cancers is someone that may be good for a genetic evaluation. Individuals that have multiple primary cancers, so for example, having bilateral breast cancer, bilateral renal cancer, or certain cancer patterns like having breast and ovarian cancer or colon and endometrial cancer in one individual is suspicious. Certain cancer types are just more common to be associated with hereditary cancer risk. So, for example, ovarian cancer and pancreatic cancer at any age meet criteria for genetic testing. We know that ovarian cancer, close to about 20% of cases are due to an underlying genetic cause, as opposed to that 5 to 10% for other cancer types. And then some rare cancers like childhood cancers, sarcomas, are also ones that raise some suspicion for hereditary risk. And then having multiple family members with cancer, same or different types, and then certain physical features or findings on screening procedures like multiple colonoscopies or multiple atypical skin findings. And of course, having a family member with a positive genetic testing result is always an indication for someone to be seen for genetic evaluation to see if they may qualify for testing for that variant in the family. NCCN guidelines are the best resource right now to find the most up-to-date testing criteria. These do change periodically, sometimes even multiple times a year. So it's good to have the most recent guidelines and the most recent link to guidelines, which we'll provide to know what that criteria looks like for your patients. So for example, patients diagnosed with breast cancer at or under age 50 with bilateral tumors, with triple negative breast cancer, metastatic breast cancer, or patients with breast cancer and Ashkenazi Jewish ancestry qualify for genetic testing based on those factors. In comparison, you can see for pancreatic cancer and ovarian cancer, the criteria is very broad. And so it includes anyone with a personal or family history. So anyone that has their own personal history of pancreatic or ovarian cancer, or who has a first-degree relative, so a parent, a sibling, or a child with pancreatic or ovarian cancer, would also meet testing criteria. There are a couple important points to remember is that thinking back to that first slide, only about 10% of cancers are caused by inherited risk. And so that means most of the patients that we see for genetic testing do not have an identifiable variant that explains their personal or family history of cancer. For some patients, this is reassuring to know that their cancer is most likely not inherited. But for other people, it can be difficult because they can't find an answer or an explanation for the cancers in their family. It's important to know that cancer risk can be inherited from both male and female relatives. So taking a family history of both sides of the family matters. We often hear of maybe a patient who is male, whose mother was diagnosed with ovarian cancer, maybe told that they don't need genetic testing because they're not at risk for ovarian cancer. But certain gene mutations can have risk for other cancer types, like we can see with the BRCA genes, for example, breast, ovarian, pancreatic, and prostate cancer. So that male individual would meet testing criteria based on his mother's ovarian cancer diagnosis, and his prostate cancer screening or screening for pancreatic cancer may be indicated based on their genetic status. It's also important to note that for most inherited cancer syndromes, the cancer risk is not 100%. So having a gene mutation doesn't guarantee that you'll develop cancer. And some patterns of cancer in the family may look like they're skipping a generation because an individual may not have developed cancer or developed cancer at a later age than we would expect for that gene or that syndrome. But it's important to know that not everyone who has that gene mutation will develop cancer or will develop cancer at an early age. And so we need to think about that when we look at a family tree. I want to talk a little bit about how germline genetic testing works when we see patients for hereditary cancer testing. As we know, DNA is our genetic information. It's present in all of the cells in our body. Typically, we look at DNA in blood or saliva for genetic testing. We see patients virtually here at University of Michigan and often send saliva samples. There is a little bit of user error when we do that type of testing to make sure that patients are following the directions and submitting the right amount of saliva. We prefer to use blood when possible, but both blood and saliva are equally accurate in terms of testing. So we'll have the patient complete their sample, like I said, either through blood or saliva, and then this gets submitted to a genetic testing laboratory. We decide which lab to send testing to based on patient's insurance, the lab's technology, which genes they have available. There's a number of factors that decide where we would send the testing to. Then their sample is essentially sequenced or read through letter by letter to detect any variants in the genes that we ask the lab to look at. And this can range from 1 gene to up to 80 genes, again, depending on the clinical indication and our level of suspicion for hereditary risk. Once the lab sequences the DNA, looks for any variants or changes from what we would expect the normal DNA to look like, they write up a lab report or summary of what, if any, genetic changes were found. This gets reported back to the genetic counselors and the ordering clinician, and then we would share this information with the patient and their care team so that they can use this information to be screened appropriately or treated appropriately for their cancer diagnosis. Most often, we offer patients multi-gene panel testing, although this is something that has changed and likely will continue to change over time. Like I said, most labs offer options ranging from 1 gene to up to 80 genes, depending on our differential diagnosis and the patterns of cancer that we may see in the family. Updated technology has allowed us to offer this more complete, comprehensive testing for a lower cost. So patients that may have had testing back in the early 2000s could have been tested for 1 or 2 genes, maybe BRCA1 or 2, and it cost thousands of dollars per gene. Now we can test for multiple genes through one test, through one sample, for roughly $250 out of pocket. But in most cases, if people meet the testing criteria that I showed on previous slides, most patients are not paying anything out of pocket for their testing. And so this is important to think about for individuals who maybe had testing in the early 2000s, just had BRCA testing, just had Lynch syndrome testing, that may qualify now for more expanded testing, given that we can do these broader panels all through one sample, again, for usually not more than $250 out of pocket, but in many times or many cases, $0 out of pocket. Usually panel testing is recommended for most of these red flag cancer types seen in the NCCN guidelines. So for breast cancer, at minimum, there's probably 15 to 20 genes that we would test for rather than just BRCA1 or 2. So in summary, we know 5 to 10% of cancers are due to hereditary risk. The majority of cancers are sporadic and those just happen by chance. Those that have cancer histories suspicious for hereditary risk are the best people to be seen for genetic evaluation. Genetic testing can impact cancer screening, treatment, and risk for other relatives, and truly can provide life-saving information. Certain cancer types and patterns of cancer in a family can help identify individuals at higher risk for cancer. And changes to technology have allowed us to test for more genes at a lower cost for patients. And so it's important to consider re-referring patients or discuss additional genetic testing for individuals that may be tested years ago. Thank you. Have a good day.